Hi, this is Dr. Peters, and today we're going to talk about anti-infectives. So let's get started. When we think about anti-infectives, think about it as an umbrella for antibiotics, antivirals, and antifungal medication. What I'm going to talk about in this slide set is more antibiotics, but I will also touch on the others. So how do they work? Well, they can be either bactericidal or bacteriostatic, and that is with antibiotics for bacteria. Viruses are different. Viruses, we have to kill the entire cell in order for the virus to be killed off. So there's various actions that take place depending on the antibiotic, depending how it's put together. So it either interferes with the bacterial cell wall for bacteria or prevents the cells from getting into the bacteria by using specific substances and then stops their growth. Or it can just interfere with the steps involved in the synthesis of the bacteria. It can interfere with DNA synthesis, and we see this a lot with antiviral medications. And it can also alter the cell membrane, the permeability of it, and then it allows cellular components to leak out of it, which is what they're trying to do, is destroy it or prevent new ones from growing. Now, this is a particular slide, and I'm not expecting you to read it. I mean, we can go up a little bit closer, but what I just want to point out is drug therapy across the lifespan, we have to always closely monitor everyone, especially if you have comorbidities, which would be diabetes, liver issues, renal insufficiency, kidney disease, heart disease. So of course, then remember, it's going to affect how the drug is possibly absorbed, distributed, metabolized, and with kidneys, excreted. With children, we want to make sure that we watch closely, and as well as older adults. Remember, with the aging process, your drugs are not going to be absorbed as readily or metabolized or excreted as readily as if you are a healthy adult. And I'm not saying older adults aren't healthy, it's just the normal aging process that changes. All right, so anti-infective activity. So they vary in their effectiveness against invading organisms. So it just depends, again, on the specific medication. Some are selective, meaning that is more of a narrow spectrum antibiotic, or some are more of a broad spectrum, and they are effective for a lot of organisms. There's two different ways to make it easy to understand antibiotics. Are they bactericidal? Do they kill the cell? Or do they prevent reproduction of the cell? And there's a lot of each that's out there. I think there's a lot more bacteriostatic medication for antibiotics, but there's both bactericidal, where it just kills the cell, and bacteriostatic. And one thing I want to make note is that we want to make sure that your immune system takes over also. We don't want, and I think of anti-neoplastics for cancer. We don't want, the goal is not to give as much medication to kill off every single cell. We want to kill off cancer cells, but yet let your immune system be able to take over and kill cells also, because you don't want to wipe out your entire immune system. And so I think of this as a similarity when we're giving antibiotics or anti-infectives. So it's important to know narrow spectrum versus a broad spectrum. I know we had talked about this prior, but a narrow spectrum is only a few organisms. So we want to try to aim to choose an antibiotic with a narrow spectrum of activity. That's what cultures and sensitivities are for. There's a lot of antibiotics that are broad spectrum, though, and can treat a wide variety. So when I choose something, and I always go back to a urinary tract infection, I know from research done what organism usually is the most common in a UTI, which is E. coli. And I know by research being done, evidence-based, that Bactrim or a sulfa drug works really well for urinary tract infections, but it's a broad spectrum antibiotic, meaning that it doesn't only kill E. coli or stop E. coli from growing, it stops multiple other types of organisms. So the goal is to try to narrow it down as much as possible. And I'm just going to show you this slide here. I'm sorry that it's kind of messy here. All right, so these are some examples of narrow spectrum. So for example, penicillin, not amoxicillin, but penicillin G. That's very specific to strep pharyngitis. It doesn't really kill any other bacteria but strep pharyngitis. Clindamycin is more narrow with fewer bacteria that it can kill off or prevent from growing, as well as metronidazole. And then when we get to broad spectrum here, these will affect a wide variety of bacteria, gram-positive bacteria and gram-negative bacteria. So as you know, these are prescribed widely, and there is nothing wrong with that. It just needs to be prescribed carefully. And when we can get a culture and sensitivity to ensure that they're on the right antibiotic, then that's what needs to be done. If someone comes in with a common cold, that's another story because most likely it's a virus, but let's just say they come back in 2 weeks and you're suspecting it could be a bacterial, say sinus infection, or let's say an otitis media, an ear infection. We don't necessarily culture that. We don't culture the ear if it's an inner ear infection. We don't culture sinuses. We only culture sinuses. It's done by ear, nose, and throat physician, and it's when you've had sinus infections over and over and over and over, very recurrent. Run of the mill? No, we don't. So what do? We have to choose an antibiotic that is as narrow spectrum as possible, but yet will end up killing the bacteria or stopping the growth of the bacteria. So research shows that amoxicillin does work well for otitis media because we know that with evidence. And it's the best antibiotic to start with. You don't want to go for some of the big bang stuff, and vancomycin is a narrow spectrum also. You just don't want to give vancomycin. We want to give amoxicillin. So if it's confusing versus broad versus narrow, please let me know. But think of broad spectrum is it can affect multiple bacteria, whereas narrow spectrum, there's not as many bacteria that it can affect. This is a slide that I just mentioned, actually, how we want our immune system to work. So the goal of therapy is to reduce the population of the bacteria or organisms for our immune system to start to work. As we know, it is a complex process. There's chemical mediators such as interleukins, complements. You have your adaptive immunity, your T cells and your B cells. So there's many things going on in your immune system. I know you're learning that in patho now, as well as leukocytes, your white blood cells, lymphocytes, antibodies. All right, so let's get to this topic, resistance, because it is the blue light special for the last 20 to 25 years. We do know that there's a lot of antibiotics out there that are resistant. And there's multiple ways of resistance, but what the problem has been is they've been overprescribed, or you're not taking it for as long as you should. And for example, let's take azithromycin, a Z-Pak. That's been prescribed a lot. It's a very easy one to take, less side effects. It's only 5 days. It's only once a day. So no wonder why it's been prescribed a lot. But what can happen? Let's just say you're sick. You have a sinus infection. You're treated for that. And on day 3, you're like, gosh, I feel so much better. And then you stop taking it. Remember, your symptoms go away before the bacteria is actually gone. So you still have some in your system. If you stop that antibiotic, that bacteria can become smart and start replicating into a different strain. So that is one area where resistance starts, is not finishing the antibiotic. All right, so I just want you to review this, which is basically how do you acquire resistance? You produce an enzyme, it deactivates the antimicrobial drug. I just explained this in layman terms, what happens when you get an infection. It basically gets smart and it turns into a superbug. So at that point, it can take on a variety of these by altering the transport to exclude the drug from active transport. It can alter all the binding sites that then all of a sudden when you take the medication again, it's not going to accept the drug. Remember receptor sites. We're not going through that. All right, so how do we prevent resistance? If you go to the CDC website, they have a campaign for preventing resistance. It's a lot of education. And I still very frequently have patients come in and want an antibiotic after 2 days, 3 days of an infection that I feel is viral. There are multiple hundreds of viruses out there, and usually things are viral. I'm not saying I discount bacteria. It's taking a good history. So how do we prevent resistance? We want to make sure that we are treating a bacterial infection and not a virus. We don't want to overprescribe. We want to make sure what we are prescribing is particular to what we think is wrong with the patient and what we think is the bacteria. For example, the UTI, young healthy person, most likely E. coli. So I know what medication I'm going to go to. I'm still going to do a urinalysis, culture, and sensitivity before I start the antibiotic because I want to make sure. There's always the case where the culture is going to grow out a different bacteria, and then the antibiotic that I just gave perhaps might not work for that specific bacteria, and then I need to switch it. That's what the sensitivity is for. Other ways to prevent resistance, making sure that the doses that are prescribed are the way they should. So they shouldn't go home and say, I'm only taking half a pill. I'm not taking the whole one. Well, that's not going to do any good because we know by research that's been done in the lab that you need the specific dose that's indicated as you look in your drug book for an antibiotic regimen. If it's recommended to take for 7 days, it should be taken for 7 days and not too long, but not too short. Also, finish even when you're feeling better, which I've talked about. Only take if necessary. And I've ran into this where patients say, you know what, I know I get this every year. Could you just put a refill on that? And the answer is always no, because then that's when you start taking them when maybe you have a virus and you really don't need the antibiotic. I always say the less antibiotics in your life that you take, the better off you're going to be when you get older and you perhaps maybe really need an antibiotic. Okay, so let's talk about culture and sensitivity. One important thing that I want you to really remember is that when you can get a culture and sensitivity, it should be done. As I talked about before, we don't really get sinus cultures unless it's recurrent, but we're a nurse working inpatient. Usually cultures are done. You can get it from the blood. You draw a blood sample. And how do they do blood cultures? There's different ways, but a most common way is to get a blood culture and then they come back after a certain amount of time and then get another blood vial from a different site. So whether it's the right arm versus the left arm, it's because you want to make sure that you try to capture the bacteria if there's bacteria in the bloodstream. Sputum, urine, wound. That's commonly done inpatient and outpatient. I see a lot of MRSA, the resistant staph aureus. So culture and sensitivity first. Why do you do that before an antibiotic? Because we want to capture the bacteria. And if you give the antibiotic first, there's a chance that you're not going to get a great sample of bacteria that's going to grow out, and then you don't really know what's going on. So you grab the culture and sensitivity first. You don't have to wait for culture and sensitivity results before you start an antibiotic. If you're inpatient and have a specific organism, say you have pneumonia, the physician, if he's not sure exactly, or the nurse practitioner or PA not sure exactly what pathogen it is, a broad spectrum antibiotic is usually ordered until the results come back, and either we will add more of a narrow spectrum antibiotic or discontinue the one and then start the new antibiotic. Okay. Now, there's sometimes when we need to take an antibiotic as prophylaxis or prevention. There's very few reasons to take a prophylactic antibiotic. But the reasons to take one is if, let's say you have a valve replacement. Remember, teeth are closely, and it's vascular, and it's closely related to the heart and as well as many other health issues. It's vascular. Easily bacteria can get into the bloodstream. So if you're having dental work and you have valve issues or valve replacement, valve disease, then usually dentists will order antibiotics. Augmentin is usually effective. Amoxicillin is usually effective for that. Another reason is abdominal surgery. If you're undergoing major abdominal surgery, we want to reduce the risk of infection. In reality, we will see prophylactic antibiotics given for other types of surgeries or other reasons. Number one, I just want you to think it might not be right. And number two, look it up. And medicine's a gray area. So you're going to see providers do things that may be off-label. It's called off-label, like not in the guidelines or recommended. That's what medicine is. But it's our job, your job as nurses, to say, is that right or is it not right? Let me look that up and let's find out. But really just understand prophylaxis used for that. Like when I go to third world countries, I take hydroxychloroquine for malaria because it's an endemic area. So I take that, and also I have ciprofloxacin in case of traveler's diarrhea. Although I have to say I've never needed to take it. And most time our team never has to end up taking it, because when you go and travel, you end up having diarrhea anyways, and then it goes away. It's just because you're not used to the food or the environment. All right, so let's talk about adverse reactions to anti-infective therapy. I made some little squares here because I want you to pay attention that there's always going to be side effects. As you probably know, you've picked up an antibiotic and you get the pamphlet and it has 25 to 50 different side effects. It's almost as if, okay, I'm not going to read this, otherwise I'm not going to take it. Most every drug has a side effect of constipation, dizziness, diarrhea, nausea. Those are normal, common side effects with most medications. Now, some side effects can be diarrhea, but depending on the antibiotic, it could be more of a serious thing. For example, clindamycin is notorious for causing C. difficile, the Clostridium difficile. So diarrhea is a symptom of that. So we want to watch that patient closely and tell them, if you have excessive diarrhea, if you have diarrhea, please call your provider and let them know. That needs to be watched closely. Whereas amoxicillin, we know C. difficile is not a common side effect, so I will tell my patients, you know what, you may get a little bit of diarrhea. It usually will subside and go away. If it does not, please let me know. Make sure you're drinking fluids. I tell everybody that with antibiotics. Any medication, for that matter, because we think of excretion. So when we think about teaching, you're going to tell them these are common side effects. If this happens, if it becomes excessive over a couple days, if you're going several times a day, you need to call. But yet, if it's a specific antibiotic that you know causes electrolyte imbalance or severe diarrhea, then you say, if you get diarrhea, you call. Now, there's some other adverse reactions that we definitely want to pay attention to. One is kidney issues. Do you have previous renal insufficiency or kidney disease that we need to really decrease the dose? How would I know to decrease the dose of an antibiotic? I look it up, and it'll say if your creatinine or GFR, it's called your glomerular filtration rate is between this and this, then prescribe this dose instead of this dose. So that's how I determine what patients will have if they have kidney issues already. But let's just say this medication is known to cause kidney toxicity. You want to monitor. First of all, you want them to make sure they're flushing their kidneys with water. And you want to monitor their renal function. Renal function is done by drawing your blood. So you get a basic metabolic panel, BMP, or a CMP, complete metabolic panel. That includes your blood urea nitrogen, creatinine. This all has to do with how your kidneys are working. We also look up the GFR now. What I just mentioned, the filtration rate, tells me how well the kidneys are working. Also, pay attention to the urine output. If they're inpatient, it'll be easy to do that. So, kidney damage. Now I'm going to jump down to the super infections, C. difficile, and we just talked about the diarrhea, so I'm not going to repeat that. But liver toxicity is another one, especially with HIV drugs. Those are notorious for causing liver toxicity. So now we need to watch liver enzymes. So if you get a complete metabolic panel, it's going to have these liver enzymes on there. ALT, they're transaminases, they're called. They're enzymes that are in the liver, and if it becomes toxic, they start releasing into the bloodstream, breaking down. AST and ALT. If those become elevated, we have to suspect that there's something going on with the liver, and what do I do first is look at their med list. And just remember, as we're going to learn in future videos, different antibiotics require different monitoring. Now, here's the differences between viruses and bacteria. In viruses, the entire cell has to be destroyed versus bacteria, it works a little bit different. It's either static or cytal. It doesn't necessarily have to kill the entire cell. But in viruses, it does. Also in viruses, the white blood cells are usually lower than normal. So if you get a CBC, that's a complete blood count, it's going to show your white blood cells. That's all I'm going to focus on right now. There's a differential that's involved that has lymphocytes, neutrophils, eosinophils, and other things. But right now, let's just talk about white blood cells. It's an indication of infection. I'm going to use just a standard 5 to 10 million is normal for a value. Now, if you have a virus, many times if you have your blood drawn, it will be lower than 5 if you have a true hefty virus going on. Sometimes you can have a viral infection and it can still be normal. Sometimes you can have a bacterial infection and it can be normal also. Once it gets into the bloodstream, the white blood cells are going to go up with bacterial infections. So I wouldn't be surprised to see 16,000. I said million, it's thousand. This one could be like 3,000. So just to give you an example, now every time you have a virus or a bacteria, if it's outpatient, we don't draw CBCs for everybody that comes in with a virus or bacteria because it's localized. It's maybe you have bronchitis and you need some, monitoring and just some expectorants, and you're watching the patient. Or if it's bacteria, if you do suspect a bacterial sinus infection, or you have a UTI that comes back with E. coli and you give an antibiotic, we're not going to draw CBC for that unless this patient's really sick. If they have a fever, again, it's all about taking that good history. Antivirals are very specific, their treatment is. So if we give a cyclovir, it's very specific to the herpes virus, which can treat many things because as we know, like there's shingles, there is cold sores, that's all herpes virus, as well as genital herpes. And then when we go to influenza A and B, then there's a specific drug for that. Whereas antibiotics, we learned about broad versus narrow spectrum. As we know, there's many choices, and we have a lot of bacteria that can be covered with just one antibiotic. So now here's some tips that I want to leave you with. Always go back to safety. When you're taking an exam, safety. As we move on, when you get into adults 1, adults 2, ABCs and safety, airway, breathing, circulation, safety. Right now for this pharmacology class, let's just think drug administration and safety. Know the medication rights because that's what's going to help you determine that you're providing safe care. Minimal harm is the goal with the maximum benefit. Let your immune system work, and always have the nursing process now in your mind. ADPI, your assessment, your diagnosis, your plan, your intervention, and your evaluation with every single thing that you do. If you don't know something, if you see something on a test that says what's your first priority and you're missing a component, you're going to look it up. Always err on the side of caution. Real life, you don't know it, it's okay, look it up. Adverse reactions. If you see anything on an exam, any adverse reaction that can be a problem, you want to stop. And then you want to notify the physician afterwards. You don't want, because put yourself in the shoes of being in the hospital as a nurse. You don't want to notify the physician but yet keep something running. You want to stop it, notify the physician. Kind of like when I was talking about labs. You don't want to call the physician before you look at the labs, because then they're going to ask you what the labs are and you're not going to have them. All right, and that is all I have to say about this.